Hello, everyone. We will start the second session with almost 30 minutes like behind schedule. And may I introduce, next to my right is Dr. Kan from Kyungyang General Hospital. To my left is Dr. Lam Ho from Hong Kong. Professor Phạm Mạnh Hùng from the Vietnam National Heart Center, Dr. Panipa from Thailand, Dr. Đinh Đức Huy from Tâm Đức Hospital. And may I introduce the first presenter, Dr. Nguyễn Bích Diễm, with the presentation entitled Complication During Staged PCI, How Should We Treat? Switch the agenda.
Good afternoon, everyone. Good afternoon, Mr. Chairman and panelists. And I am Dr. Bích Diễm, come from Heart Institute of Ho Chi Minh City. Today, I will present a case report about the complication during stage BCI. I was not successful in management this complication, but with the spirit of learning from sharing. So I want to share this case for everyone to learn how should we treat when we face with this complication again. And my patient is a female of 74 years old and patient with a history of unstable angina, CAG, so free vessel disease. Patient was BCI with 1 DES in LAD and 1 DES in RCA and still have significant stenosis in proximal circumflex. The patient was present with a worsening chest band and started with 4 days before examination was no abnormal. The echocardiography showed that hypokinesia in inferior ward and EF about 56%. The turbulence was under 14. And this is ECG showed that the signus rim and the Bohr R wave progressive progression in D2, D3, and EVF. And the CAG 1 month ago showed the free vessel disease. As you can see on CTO in LAD and significant stenosis in circumflex and proximal of RCA. The patient was treated with 1 DES in proximal RCA and 1 DES to ostium to middle LAD, and the plan is to stage BCI to proximal circumflex. And with this patient, we take elective CAG for this time. The CAG showed that no restenosis in previous stand in LAD and proximal RCA, and black in circumflex is about 70 to 80%. And with this patient, we plan to BCI the proximal circumflex with direct stenting technique by 1 DES, 1.75, 18 to proximal circumflex. but we could not push the stent through the ostium of circumflex. So we have to predilate with a balloon 2.5 15 millimeter, and the problem occurred here. We could not retrieve the balloon catheter to the guiding. And you know the cause of the balloon entrapment in the vessel. Maybe the balloon failure to deflate, or the balloon fracture, or the balloon interact with prior stent. And after we check on the system, on the B-side system, we find out the reason is the balloon was stuck in the stent tube in ostium LED. And now, what should we do for this patient? The patient statement right now was stable, and we have more technique to withdraw the balloon entrap in the vessel. But in this case, the balloon entrap in the stent tube, so we don't know how to do with this case. And the one thing we can do is trying to pull the balloon back, and because it is the first time that we face with this complication, so we feel a little bit nervous. So we are losing the Y in circumflex, and this makes more difficult for us to solve this problem more and more difficult. As you can see, when the Y still in circumflex, is the balloon will straight and go answer to the vessel. But when we're losing Y, the balloon will a little bit folded. So we have more difficult when we pull it back. And the patient statement right now, the blood pressure slightly decreased. Now we come for help from a surgeon, from anesthetist, and other staff in cath lab. The only one thing we can do right now is continue to withdraw the balloon. We use another wire to LD and another wire to marginal, and one NC balloon in left main LED to anchor the whole system for pull the balloon back. And when we made more attempt to pull the balloon back to the guiding, the effect on stent LED maybe it makes stent LED deformation. And in this situation, when we can withdraw the balloon into the left main and guiding catheter, we find out something abnormal in left main and guiding catheter, as you can see that. And when we withdraw on the system, we cannot withdraw on the system, and we see this picture. The balloon still entrapped in the stent, and the proximal spark of the stent got deformation, as you can see. And right now we have a heart team consultation and decided to emergency surgery. At the operation room, the patient was CBG with 2 bypass graft and open the aortic to cut the deformed stent and withdraw on the system. And this is the real picture we can see about the complication. The balloon was stuck in the stent tube and stent deformation. The patient was after that the patient was stable, and the patient was started DBT after 2 days when the bleeding was controlled, and fortunately the patient was discharged after nearly 2 weeks and feel better until now. And when the patient was safely, we check on the procedure that we made for patient, and we find out some problem that we made for my patient. The first one is when we do the first phase beside strategy, we do the beside in ostium LED. Why we have a significant lesion in circumflex need to be BCI. And the second one, when we putting stent in ostium LED, we make the stent protrude into the left man a little bit more, but we don't identify. The third one is we cannot recognize when the wire passing through the stent tube when we go the wire to circumflex. And the fourth one, when we feel so nervous, we loosen the wire in circumflex. And last but not least, but is should we stop and get help from surgeon early? After all, there is some discussion for this complication that we have stuck balloon in the coronary artery, especially stuck in the stent tube, is a very rare complication. But if it happens, it can lead to the life-threatening complication. The most effective treatment for us is prevention before it happens. And in patients with multivessel disease, especially with LED or circumflex ostium lesion, we should choose the appropriate first phase beside strategy. We should base attention for the feeling when we go the wire to the vessel, so we can early identify why the wire passing through something abnormal. And last one is a very important thing when we face with any complication is to keep calm. That's all for my presentation. Thanks for your attention.
I think this is a very challenging situation. Yeah, like what you said, prevention is the most important. But once it happened, it's also my first time to see. I haven't encountered this complication before. Difficult to think about any solution. I just see your case and then think about some suggestion. Is we sometimes, if we cannot push the balloon in the side branch, we use anchor balloon. So if we put the wire in the AD, do anchor balloon with anchor balloon and then pull, will it give better force to pull the balloon out? Do you understand? Anchor balloon in AD stand first and then pull. You may not be able to pull it completely out, but maybe just partially, and then inflate the balloon, then destroy the stent struct. Then maybe it will be easier for you to pull it out. Or how about the others? Can you think about any better way?
So I think in other ways. So if I got this problem, of course, even we use IVOS, we know that this already like go beyond, go beyond, or it's like strut and then under strut and then strut again. It's really difficult. But I just thinking that maybe if I were you, I would do the pot first, because you already figure out that it's already like beyond the osteo. And then do the pot and see if the strut is going to be like wider, and then just cut the distal of the balloon and use a geisila. Yeah. And then like move the geisila really close to the strut, and then I'll try to pull it out. Yeah. So any other idea?
Yeah, I think it's more important that we have some more support. So I think it's an anchor balloon in LED, and then try to push a guy plus, maybe a very good small catheter in very close to the balloon, and then do port for the very proximal of the stent. Hopefully that we can make the strut becomes bigger, and then the balloon can come out. Yeah. But the most important is, I think we have to keep the wire in. Yeah, when you lose the wire, then you lose everything. You have no more chance to get the stuck balloon out.
Thank you, Doctor. Thank you, Dr. Pui. Yes, sir. Okay. Actually, I have one case a little bit similar with this case before, but on the ostium of the RSA. when one of my colleagues to try to do and they cannot put back whole thing, including the balloon. So as I think I do another puncture to have a second guiding. It's a bigger, and I try to do something similar to somewhat you retrieve the lead when you want to retrieve the lead. So I try to push a larger guiding to push to hold the awesome of the assay, and then we try to pull out the balloon from the first guiding. So I successful with that case. But in this case, I think we can do the second guiding catheter, and we can try to push one balloon in the stand of the LED to do something like an encore, and we try to do. And other way, I think we try another thing to wire again to LCH to try to go in the same thrust, and then using the second balloon to inflation. But the more important thing, I think we need to the second guiding to manage it. So this is my experience. Yeah, thank you.
I think that the first thing to do before deleting the start of the stent is that we will push the balloon forward, and then we will use the technique of refolding the balloon, meaning that we will use slow pressure for example, 4 atmosphere, and then deflect it rapidly so that the profile of the balloon will be smaller than after the inflation, and then we may take it back, pull it back before trying to put a second guide wire, and then using a second balloon to open the stent stud. Yeah.
Difficult case, and I fear this situation. So the patient had stand in the proximal LD. So when we do the BCI in the proximal circumflex, you make sure the drug stand not cover the osteo circumflex with the imaging. For example, the OCT, or you zoom in the angiogram to bigger, and you make sure the stand track not cover the osteo circumflex before you do the BCI to circumflex. And your situation, I think, difficult for us. Thank you.
So maybe I ask the presenter some more challenging question. For example, NC track, the balloon NC track. Do you know what is the response of the NC balloon while you pull it? Did you try it before? You mean pull the NC balloon? What will happen?
I cannot.
You don't know. Oh, okay. There's one more tips and tricks to share. Usually in this situation, you need to open the same band of the NC balloon and then try to pull to do one experiment for you to feel what is the maximum force that you can give. Sometimes you can pull, and then with certain force the balloon can break. Some of the balloon will not break, they will elongate and then break. Different depends on the band. For example, NC track will elongate a bit, a certain part, and then break. Some of the NC balloon you just pull and then it will break at the junction. So while you pull, it's better to open a same band, same NC, and try the force. Make sure you don't do higher than the expected force. Otherwise, the NC balloon will break. Yeah.
I think that we can also use a guide extension to facilitate the withdrawal of the balloon after trying to refold the balloon.
Okay, so thank you so much. So I think we move to the next presentation. I would like to invite Dr. Nguyễn Viết Lâm.
Good afternoon, ladies and gentlemen. My name is Lam from Huế Central Hospital. Today I am very honored to be here when I am participating in SSIC 2024. And now I am introduced about my case about no reflow phenomenon. And no reflow phenomenon is a serious complication that occurs after opening of an infiltrated artery that results in a worse outcome. And about definitions, angiographic no reflow defined as a less than TIMI-free flows. And about pathophysiology, there are two main factors contributing to pathophysiology: is distal embolization, cardiomyocytes, and ischemia reperfusion, and the last is the individual susceptibilities. And how to deal with the no reflow phenomenon? First, we are exclude not cause, check HT and hemodynamics. And the next step, we balance the vasodilator agent via a delivery system. And I had my case today, a 70-year-old female patient was admitted with angina and dyspnea. About medical history, she has a type 2 diabetes and hypertension, and a vital sign was normal. And ECG showed that ST segment elevation in D2, D3, and AVFs. And ST segment depression in D1 and AVLs. About echocardiography research showed that the hyperkinesis of the anterior walls and EFs about 42%. A laboratory test was with elevated past extremity. And she was diagnosed with posterior STEMIs. Mills EF has failure type 2 diabetes, and treatment with aspirin, ticagrelor, rosuvastatin, dapagliflozin, perindopril, and enoxaparin. And this patient was indicated for emergency PCI. About coronary angiography, so that's about coronary angiography, so that lemon have a 40 to 34 to 40% steno, and LD, so that's subocclusion of the proximal, and 90% steno at proximal diagonal, and LC has a mu steno of ostium. And about RCA, so that 95% of distal segment before the bifurcations provides collateral circulation to the LEDs. And so what should I do for this case? And my team decided to perform a copious artery besides RCAs. We are perform a pre-dilation with semi-compliance and stenting with stent 2.75 mm. And angiography, after that, you can see that's a TME flow about 0 to 1, and the patient has a severe chest pain, blood pressure drops, and on the monitoring so that the third degree AV blocks. And this patient was that no referral phenomenon. Immediately, we are intervened about atropine, dobutamine, and norepinephrine interventions, and bolus of nitroglycerin and epinephrine via guiding catheter. And after 1 minute angiography, so that TME flow not improve. So my team deciding perforated balloon techniques for this case. And how to do a perforated balloon techniques? We do a semi-compliant balloon with a diameter about 2.5 mm or larger, and after an inflated balloon with a normal saline, and after inflated, we 6 to 10 how was been by using a micro-buncher nozzle as the balloons. And the next step, we push the balloon to the distal of ACH and plus of nitroglycerin and epinephrine injection in the distal ACH using a perforated balloon. And this research angiography after 5 minutes. You can see TME flows. However, the patient still angina persistent and unstable hemodynamics. And my team decided to LAD size. About LD size, we are using a guiding EBU, guiding a filter, and run through, and lesion prepared with a semi-compliant 2.5 mm and 2.0 mm, and non-compliant 2.5 mm. And next step, we are stenting at the LD with a middle LD stand 2.5 mm and proximal LD to the osteo of LD with stand 2.0 mm. And angiography so that no flow of LDs. And we are continue using use perforated balloon techniques for the LEDs. And after 5 minutes, you can see the TME flow was improved, and this TME 3 flow of LD. And after 7 days, we are angiography, and the angiography so that's a 75 osteomorph stenoverb LC complex. And my team decided to plan left main LD stenting with a stent 3.0 mm and kissing balloon with NC 2.0 and 3.0 and 2.75 mm, and POT with NC 2.0 mm, and the final angiogram with a good results. And I have a conclusion. Coronary nodal flow is frequent occurring during PCI intersecting of STEMI. Prevention and treatment are paramount important because of full benefit of reperfusion is recognized. Only coronary flow is normal, and perforated balloon technique was a rapid, safe, and effective method to deal with nodal flow phenomena. That's all my presentation. Thank you for listening.
Thank you so much, Dr. Nguyễn Viết Lâm, for very interesting case. especially for the tip of the handmade perfusion balloon. So it is very important learning point here. So you can do the handmade perfusion balloon in a case you want to deliver the drug to the distant parts of the coronary. So may I ask our panelists a question or comments about the case?
Yeah, may I have a question? So, have you checked with imaging that there is no dissection from the proximal or distal end of the stent, just when you recognize the no reflow phenomenon?
Yes. At the moment, the IVUS mechanism has no problem, and I cannot do IVUS in this moment, and do not check the dissection in the stent. However, after injection of nitroglycerin and epinephrine, the TIMI flow was improved, and I think it's a no reflow phenomenon in this case.
May I ask the question about the drug that you use for the no reflow? I see you use adrenaline plus TNT. So why will you choose this combination? Because some papers said TNT had no effect on no reflow.
Can you repeat the question?
Yeah. I see you had used the two drugs for the treatment of no reflow. One is adrenaline, and the other one is TNT, nitroglycerin. So why will you choose these two drugs?
Nitroglycerin in this case. In this case, because of this patient has no reflows in the distal of ACH, and I have used dobutamine and norepinephrine to stable hemodynamics, and after that I have a little of nitroglycerin to distal ACH to improve the flow inflow of ACH.
Okay, thank you.
Yeah.
Thank you. So I also one question. So why you decide to do for the left side with a very complex PCI in the same procedure?
Yes.
Very interesting. Yeah. Do you think can increase the risk for the patient when you decide to do the very complex PCI for the left side?
Yes.
I have one question for you.
Yes. This patient was diagnosed STEMI in inferior STEMIs, and the Cupid's artery is ACH. And after we performed the ACH PCIs, this patient was not improved about angiomas, and hemodynamics is not unstable. And because of ACH, because of LED is subocclusion of the proximal and receive collateral from ACH, and so after ACH PCI we has no reflows, and I think the flow collateral from the ACH is decrease in this case, and so my team decided to LD PCI in this case.
Thank you. I have a question for you. For the artery nose flow, after you inject the nitroglycerin IC into the distal RCA. If fail, what should we do?
Yes.
Next step.
Yes. If fail with nitroglycerin, I will try the plus nitroglycerin repeats or plus other agent vasodilators such as epinephrine. Yes, and because and in this case, patient have bradycardia and with third degree AV blocks and cannot and this and contraindication for the adenosine. Yes. In another case, maybe using adenosine for the no reflux anonymous. And in the and maybe repeat the vasodilator agent and following about 5 to 10 minutes and angiography to detect the flow after that.
So just only one question.
Yes.
So how can you be sure that the patient still got a chest pain? Because the problem because of the distal embolization that you do for the RCA is not because of the LAD, because LAD is a CTO, right? Yeah. So even it has been a long time. So how can you differentiate it? And the second one is, are you were you consider to use the IABP and
yes.
in this case, because you already restore the flow.
Yes.
And another one is not the question, but is my comment. So mostly if I have such a problem in my cath lab,
yes.
I don't do the perforate balloon because we are getting old, so the eyesight is not good. So I use the thromboster instead, and then I use the nitroprusside, and then go to the distal, and then do the injection, the pullback, so you can check the flow and check if any dissection or clot is the same time. So
yes.
Yeah.
Okay. It's in my opinions in this case, after the reflow of RCAs, the TB flow was improved because of RCA provide collateral to the LAD and no reflows of RCA, so should not be the decreased flow of LD flow to collateral to LD, and so my team decided to perform the LD PCIs, and the perforated balloon techniques is a very effective for the poor patient in Vietnam because of it's reduce the cost for the patients. And about in this case, I think maybe using EABP for this case. Yes, because in my cath lab it's not EABP not available in my cath labs because of EABP is performed on a CCU.
In your presentation, I saw that there is an ST elevation on D2, D3, and AVF, meaning that the complete lesion is on the RCA. So what happens to the ECG after you put a stent in the RCA?
Yes. After stenting with RCAs, the ECG blocks the third degree AV blocks on ECG after stenting of RCAs in the distal.
Is there any modification of the ST elevation after the stent?
Yes.
after the stent in the RCA.
Yes.
Is there any modification of the ST elevation in the 2 D3 AVF?
After stenting in the RCA, the ST elevation is not decrease the amplitude, and however the ECG on monitor so that the third AV blocks after that. And after we are treatment no reflow, the rhythm is not synonymous.
Okay, thank you for your presentation. And now we move to the third presentation. Successful PCI of left main dissection following mechanical aortic valve replacement surgery from Dr. Dương Thiên Bảo.
So thanks for having me here today. My name is Bảo. I'm from the Interventional Cardiology Department at the EMC. So today I present to you, So today I present to you a 65-year-old female patient with the history of mechanical aortic and mitral valve replacement surgery due to rheumatic heart disease 20 years ago. The patient also had permanent AFib and was on the daily treatment of the VKA and the beta blockers. She was complaining about the exertional dyspnea for 1 month and was admitted to our hospital. Physical examination at the beginning showed that the patient was in stable conditions with systolic murmur at the left side of the sternum. All the lab tests was in normal range with a slightly increase in BNB level above 300 and the Paul wave progressions and T-wave inversions in V2 to V6 on the EKG. The echocardiography showed that the patient had the normal LV functions with proper positions and functions of tricuspid and mitral valve. However, there was a severe stenosis of the aortic valve with the mean pressure gradient and the maximum velocity across the valve was 52 and then 4.88 meters per second, respectively. So the diagnosis at this point were the severe symptomatic restenosis of mechanical aortic valve, and the indications for aortic valve replacement surgery was recommended for this patient. So the patient underwent the surgery, which lasts for the total of 10 hours, 30 minutes. Opening the ascending aorta, we identified the main etiology for the stenosis, which is the panus. So the previous mechanical valve was replaced by the Onis valve site 21. Unfortunately, immediately after we release of the aortic clamp and in the airing of the left ventricle, the patient suddenly developed the ventricular fibrillations and required 3 times of defibrillations. And although all of that, the patient's hemodynamic status were unstable and required a high dose of vasopressor. So the surgery team came up with the diagnosis of the ventricular tachycardia that's secondary to the myocardial infarctions. So they decided to utilize the right saphenous vein and perform the CBG with the 2 bypass from the aorta to the LAD and the RCA with the IIPP as a mechanical circulatory support. Unfortunately, during the initial post-operative day, despite the escalations in dosage of 2 vasopressor and 2 inotropes, the patient still experienced a gradual decline in blood pressure, and her hemodynamic status was gradually deteriorated. And also, additionally, the ventricular tachycardia was consistently observed on the monitor. All the lab tests showed that the patient developed the profound metabolic acidosis with increased blood lactate and come along with the surge in troponin T from 4 to 5 and then persisting at more than 10,000. And similar trends were observed in the CKMB, creatinine, and BNB level. So we came up with the diagnosis of the severe metabolic acidosis with increased serum lactate, the cardiogenic shock secondary to the very high-risk end-STEMI, and the indications for the coronary angiography and revascularizations were recommended for these patients. And via femoral approach, we can see that the LAD, the RCAs, but also the bypass to those arteries are not significant stenosis. There you go. However, the image on this view suggests that there was a dissection from the left main to the circumflex, leading to the severe stenosis. So we decided to use two wires to cross to the distal of the LAD and the circumflex, and subsequently IVUS were utilized to assess the lesions. So the finding indicate that the absence of the dissection in the LAD. However, examination of the left main and the circumflex showed that there was totally separations of the intima and the media from the adventitia, together with the presence of the intramural hematoma. So the initial dissection site extended approximately 17 millimeters from the ostium of the left main to the ostium of the circumflex, with the smallest true lumens area was measured at the 5.84 square millimeters and leading to the 80% stenosis compared to the vessel area. We also measured the dissection angle at this site, and it reached approximately 230 degrees. So we decided to use a 4x 24 millimeter stent to deploy from the left main to the circumflex, and following by the post-dilation in the left main stent segment using the 5x 15 millimeters NC balloon. And after that, a cyan blue wire was rewired to the distal of the LAD, and then using the 3x 20 millimeters to redilate the ostium of the LAD, following by the kissing between the LAD and the circumflex. And after that, we used the 4x 20 millimeters to dilate the entire segment of the stent, and further post-dilation in the left main stent segment using the previous NC balloon 5x 15 millimeters was performed. And here is the final result. The coronary angiography confirmed the TIMI3 flow in the left main to the circumflex and the LAD. So the post-PCI IVUS, we also performed it, and the results show that there was no evidence of dissections at either both the proximal or distal end of the stent edges. Also, there was no evidence of the tissue relapse. In addition, IVUS verified the adequate stent opposition at both ends. We also measured the MSA of the proximal and the distal left main, the ostium of the circumflex, and the smallest MSAs in stent with the relative expansion approximately 94% compared to the distal reference. So all the results I will show on here. So after the PCI, the patient hemodynamic status and metabolic acidosis condition improved substantially, and all the vasal pressure drops were gradually tapered off and ceased entirely within 5 days. And during this period of time, the patient was successfully weaned off from the IIPP and mechanical ventilation. So the post-PCI lab test showed that the reductions in the troponin T, also the CKMB, BNB level, and improvement in the renal functions. And the patient was successfully discharged after 22 days after the PCI. So to sum it up, this is the 65-year-old female patient who developed cardiogenic shock following the acute MI after the valve replacement surgery, and was successfully managed by the PCI with the help of intravascular imaging. And we actually do some kind of review of literature, and here are our learning points. So first of all, iogiganic left main dissections following the surgery is a rare entity. It has a wide range of clinical manifestations, from the accidentally finding via transesophageal echocardiography, like in knockout case report, to maybe it have the clinical context that present that resemble our cases where this complication was only recognized following the acute MI-induced hemodynamic instability, or maybe it could be fatal, like in Beria case report, where 3 patients unfortunately suffer from sudden cardiac arrest. The treatment options is a wide range. It could be the PCI, CBG, or maybe the conservative therapy. So from my perspective, I think it should be based on the timing of the diagnosis, the patient conditions, and the physician expertise. So in our case, the dissections was identified after the surgery, and it induced the hemodynamic instability and life-threatening arrhythmia. So PCI was safe, effective, and helped reduce the necessity for further cardiac surgery. So that's a wrap-up of my presentation. Thanks for your listening.
Thank you so much, Dr. Zentinbell. Before I answer the question, so may I remind also panelists and presenter, we have just only 5 minutes for Q&A after presentation. So please, if you have any questions, Dr. Hui.
So thank you for sharing the case, and your team just have a good case. Yeah, so my question is there any CT scan or angiogram before the surgery? And then do you notice any problem with the angiogram before surgery? And if there is no, then how can we explain there is a dissection of left main just after the surgery?
Okay, thanks for your questions. Actually, I have to cut it off. There's a lot of information to shortening my presentations. Actually, the patient had performed a CT scan and before the surgery, and the result showed that there's no significant stenosis in the coronary artery system. About the etiology for the left main dissections, I reviewed the literature, the main etiology for the left main dissection following the cardiac surgery, it could be the dissections from the aortic root, and it propagates to the left coronary artery system, or maybe the direct infusions of cardioplegia solutions into the coronary artery, the solution to paralyze the heart, or maybe the intraoperative maneuvers. So the majority of documented clinical cases, as I mentioned above, the precise mechanism, etiology remain uncertain. However, from my point of view, I think in our cases, that would be due to the mechanical injury, because the whole process of extracting mechanical aortic valve was quite challenging, because the mechanical aortic valve has already been there for 20 years. And it was supported by the fact that the patient immediately developed hemodynamic instability and life-threatening arrhythmia when we release of the aortic clamp. When the blood come back to the aorta, it indicates that it's some kind of exacerbations of pre-existing dissections of the left coronary artery system. Yep.
So I have a question regarding the sizings of the left main, because you measure it when it's already have a dissection. So would that be the oversize of the vessel or not? So what is your thought about that? And the second question is that anything at the osteo which is could be the stent deformity, because it's not a round one. So as you can see, it's the elliptical shape. So would it be possible that it's because of the guiding catheter, or you have any explanation why it's elliptical?
We choose the stent based on the IVUS. However, as you mentioned, the proximal of the stent is kind of shrink, and when we look it back to our case, the most possible explanation that would be due to the catheter engaged to the stent, because after the stent was deployed, the catheter was pushed back, and then we have to re-engage it, and it may cause the stent malformation at that proximal. Yeah.
My question is there any signs or symptom to suggest the patient has a problem with the left main? before you do Hangzhou?
Yep. Actually, because the left main dissection is a complication that's more common when we're doing the PCI procedure. However, in the patient underwent the cataract surgery, they are anesthetized. So the signs and the symptoms of ischemia, like the chest band, was hidden, totally hidden. So thanks for the closely monitor from the patient heart rate, but also the cardiac biomarkers after the surgery, we are fortunately identify early detections these complications. Yeah.
How about EKG?
Yeah, excuse me.
ECG? How about ECG?
On the EKG, it showed that the patient have the premature ventricular complex accompanied by the ventricular tachycardia was consistently on the monitor. So we decided to put the patient on the procedure. Yeah.
Thank you. Okay, thank you so much. If there are no questions, so may I invite the next presentation, Dr. Phung Chun Wu. Phung Chun Wu, yeah.
All right. So, good afternoon, colleagues and chairman. So, I'm Dr. Phung, a cardiologist from Hong Kong. So, today I will share a case of triple trouble to all of you. And I have no disclosure. And our case is a 70-year-old gentleman presented to us for chest pain for around 12 hours. So this is the ECG on the mission. So we can appreciate there is a significant ST elevation over the inferior leads. So, and we activate primary PCI for him. And this is the initial coronary angiogram. So the culprit is the mid-circumflex vessels. The right side coronary is not shown here, but it's just the recessive vessels. So there is also a very diffuse and calcified lesion over the whole LAD. So after some initial ballooning, there is a significant bifurcation lesion over the mid-circumflex and the OM2 vessels. So we'll put a 225 stent over to mid to distal third and OM2 with a standard OM2 with a 3.0 stent and with a bifurcation stenting. And this is the final result. We are quite happy with that. So the patient was then managed in CCU, and he developed cardiogenic shock with acute pulmonary edema. And echocardiogram showed a very severely impaired left ventricular systolic function. The left LV ejection fraction is around 32% by Simpsons with global hypokinesia. The right ventricular systolic function was quite good, and this information is important for us to choose our mechanical cardiac support if necessary. And the valves are quite unremarkable. So the patient was stabilized with diuretics and with inotropic support. And then around 6 days later, we arranged impeller-assisted stage PCI for him. And this is the restudied coronary angiogram. And this is for the circumflex vessels. And we can appreciate that the vessel size of the circumflex actually growed much larger when compared to the index procedure. And this is the coronary angiogram for the LAD. It's a very calcified vessels, and again with a diffuse and tight lesion over the whole LAD. So we decided to do the PCI to the left circumflex first. So we wired both the left circumflex and the OM2, and we had done an OCT and confirmed there is a malapposition of the stent over the OM2. So we decided for optimization of the bifurcation stent first. So there is quite a challenge to deliver the balloon to the through circumflex. And we use anchor balloon technique with an anchor balloon inflated over the OM2. And we, after some manipulation, this is the anchor balloon over here. And after some manipulation, we do successfully deliver the plain balloon to the mid-circumflex. But after we deliver the circumflex, there is something missed here. The stand, the previous stand is gone. So this is a great surprise to us. And we go further distally, and we see actually the stand is migrated downwards. So it's possibly being pushed down by the balloon during the manipulation. So we change our strategy. We do an angioplasty first with a 2.5 and 3.0 balloon to the migrated stand to make it well approached to the vessels. And then we settle the bifurcation with a Coulomb standing with a 3.0 stand deployed at mid to distal third, and then with kissing balloon inflation. So this is the final coronary angiogram with quite a satisfactory result. So we then move on to PCI for the to do the PCI for the LAD, and this is the OCT record for the LAD. So it's a very tight lesion over distal LAD. It's quite calcified. We can see more calcium here, and another tight lesion over the mid LAD, and all the way. This is another lesion over the proximal LAD, and it's actually a thin cap fibroathoma here. So the OCT show is a very challenging lesion. So these are our consideration at that time. The patient already had primary PCI done, and he's on dual antiplatelet therapy with a poor left ventricular ejection fraction. So CABG is, the risk of CABG is prohibitive for him. So in view of the thin cap fibroathoma, after it is well known that after standing of thin cap fibroathoma, there is a high risk of developing no refold phenomenon. The lesion was too tight, and the patient EF was very poor. So we can't just leave that alone and treat medically. And so third, there is a very diffuse calcified lesion over the mid to distal LAD, and we have to make sure that they are well settled to ensure good stand expansion and prepare for bell out. So we decided to settle the calcified lesion with rotational atherectomy, mainly done over the proximal to mid LAD with 1.5 burr for several runs. And then we further prepare the lesion with undersized NC balloon, a 2.5 balloon, to avoid creating low refold after dilating the thin cap fibroathoma. And then the mid LAD was stented with a 2.5 stent, and followed by another 3.5 stent over the proximal to mid LAD. So we then do a post-stent high pressure with a 4.0 NC balloon at the proximal LAD. Again, avoid touching the proximal LAD and the previous lipid-rich lesion. And another 3.5 NC balloon at the proximal to mid LAD, 3.0 and 2.5 balloon at the mid LAD. So after the post-stent high pressure, we check the coronary angiogram. So unfortunately, despite all the measures, and the patient still develop no refold. So we quickly give some a repeated dose of adenoscan with a Guy-Pass catheter and a Crusade microcatheter. And given the OCT findings, the most likely mechanism of the no refold would be the lipoembolization. So we also attempted a mechanical thrombectomy with a seven ventral thrombustor and a penumbra system. So this is the record of how we delivered the penumbra system, and to try to aspirate the lipid emboli and try to help to improve the situation. So we also have to bear in mind there is other differential diagnosis for the node refold phenomenon. So we give a distal injection with a microcatheter, and we show that there is no dissection, and there is a very good backflow back to the mid-LED, and confirm there is no residual stenosis. So we then give more and more adeno scan. And finally, the coronary flow improved to a TB2 flow, and the hemodynamic is stabilized. So these are some discussion points for this case. So there is a very common, during the acute myocardial infarction in primary PCI, the patient may develop a coronary spasm because of the systemic stress. And so sizing of the stent may not be accurate at that point. And thin cap fibrosarcoma or lipid-rich plaque and represent a vulnerable lesion. And it's well known that after intervention, it may develop a node refold phenomenon because of the lipid emboli. So after stenting there are several differential diagnoses if a node refold phenomenon developed. For example, it can be an embolization, either due to plaque embolization, thrombus, or lipid embolization in our case. And it also can be due to thrombosis and stent dissection, coronary spasm, etc. So distal contrast injection with a microcatheter and intracoronary imaging is very helpful to help us differentiate the causes. And for the management of embolization, we can use vasodilator such as adenoscan, nicardipine, or even in desperate case, nitroprusside. And we usually develop it with a microcatheter or a guide extension catheter, or just somebody, and our expert panel just mentioned in a PSVA case, we can use a thrombustic catheter. So the idea is to develop the drug down to the capillary bed, which is the target of our medication.
Báo cáo viên chỉ còn 2 phút trình bày.
Aspiration with thrombectomy system is also useful for lipid embolization. And some experts suggest a filter wire may be useful to prevent it from happening, but the effect is doubtful. And for thrombosis, we have to check ACT to ensure adequate anticoagulation, and we may consider giving a glycoprotein 2B3 inhibitor. So, ladies and gentlemen, these are the conclusion for this case. And preparing and anticipation of possible complication are very important for a successful CHIP PCI. And OCT gives us invaluable information about plaque composition and help us to guide our stenting. Mechanical cardiac support also allowed us for extra time for diagnosis and management should a complication occur. So last but not least, if complication occur, we have to stay calm but act fast. Thank you very much.
Thank you so much, Dr. Fu Yu, for very nice case. So may I ask our panelists, have any question or comments? Yeah.
So may I ask a question regarding the rotor? So what is the speed that you use? Do you have any consideration about the high speed and low speed in this case?
Yes.
And the second is you have slow flow. So maybe Dr. Hui also have a question that do you think that the slow flow is happen because of rotor or because of the lipidic plaque, which is in the proximal LED, which is a really big chunk of lipid?
Yeah, thank you for your question. So we usually, for the rotor patient, for the first few shifts, we usually do 18,000 RAM per minute. So depends on situation, we may use the lower speed for a polishing run. So, but the polishing one is not done in this case. So the speed is relevant because it may affect the particle you create and the risk of the subsequent node refold.
So for the second question, for this case, because we are aware of the finger fibroma, so when we do the rotabation, we avoid the area of the finger fibroma. We didn't do the rotabation over there. We mainly settle the do the rotabation over the mid to over the post more over near the mid LAD, because the calcification is mainly over there.
So my question is in case we don't have OTC, so we get no reflow or slow reflow. Do you recommend to aspirate automatically for every case?
I think thank you for your question. I think it's really depending on the mechanism of no reflow. So just as mentioned, there is other differential diagnosis, maybe a spasm or dissection. So for those causes, probably aspiration may not be very useful. So I think intracoronary imaging and also the distal contrast injection with a microcatheter is very useful for us to differentiate the cause of it.
Thank you.
Maybe I just add some comment, but not a question. Just by experience, we see that with cord, with lipid, always have, if you stand, always have no reflow. Not always, but many of the time you have no reflow. But some situation you cannot avoid standing, or you must do something. Some situation, then you do something, you will have no reflow occur. In our experience, we found that if the no reflow is occurred due to fungus, it's easier to manage. Most of the time, you just by drug is okay. However, if the no reflow is due to lipid, many of the time is not responsive to drug and is quite refractory. And because the lipid can fall in the coronary. In this sort of situation, we found that fungus aspirations can improve the whole situation dramatically. But if you don't do intravascular imaging, you cannot differentiate.
Okay, thank you.
Yeah, thank you for your presentation.
Okay. Thank you. So next, I would like to invite Dr. Phạm Hùng Cường. Yeah. Phạm Hùng Cường, or maybe the delay, yeah, flight delay. So I will ask Dr. Phạm Nhật Minh. Phạm Hùng Cường, yeah. Okay, thank you, because some changing for the presentation. Yeah. Dr. Phạm Nhật Minh, please.
So, Professor Chairman, the jury board, and ladies and gentlemen, so I am very sorry for my late presentation today due to the delay of my flight. So actually, we really have some incidents and also the accidents in your life, and today I'm going to tell you one of the most frightening moments or frightening cases of my career and my life. So actually, this the patient is just a normal case. She was a 77 years old lady, history of hypertension, and she's currently on perindopril and amlodipine. She has a rheumatoid arthritis, and she have on some kind of Medron medication and also the HCQ, and she admitted to the hospital due to the unstable angina, and otherwise she has no other sign of congestive heart failure or kidney failure, or the LVEF is still normal, and the cardiac troponin is also normal in this case. And from the right side, you also appreciate that the ECG looks quite normal. And actually, this case we did at about 6:30 p.m., the last case of the day. And actually, on that day, I have to be quite rushed because It was the birthday ceremony of my sisters. So what would you do when you have a rushing case? You have to ask your colleague, you have to ask your technician to do the case very, very fast. You have to be very, very rushing. And one important thing that you would like to do the very complex cases on the day you are rushing. So here's the CAG of the patient, and I think that all we can appreciate that the patient has quite a tight lesion on the LAD, the proximal, the first segment of the LAD, and the circ is normal. And then here's the other view showing that the patient has quite a tight lesion of the LAD, and the RCA also has the very tight lesion and unstable plaque. But with this case, we decided to do the LAD first, and then we would do the RCA in another time or the second stage. So actually, you really got what you wanted, quite a straightaway case. You can see that it is quite an easy looking LAD lesion that you can fix quite easy, and you can do other things else. So I proceeded to pre-dilate with the 2.5 compliant balloon of the LAD. And afterward, with such a normal case, we put the stent. So we tried to put a 275 by 33 of the stent. But then from here, the problem began to happen. So firstly, the stent could not pass to the lesion. So what should we do when we have a stent when it could not pass? We use a parallel wires, and we use a bigger balloon to open up the lesion before you put the stent, right? But due to some reason at that time in my cath lab, we do not have enough devices, so that the only one balloon that the technician could give me was a 25 by 15 NC balloon. It looks a little bit too big, actually, but I decided to proceed with the case right away. And this is after this is how we ballooning the lesions with the 325 by 15 balloon. And then from here, the things happen, as you can see. I have never seen a case that the hemodynamic collapsed as fast as this case. In just 30 seconds, the blood pressure down from 140 or something to just 0. And as we can see, so I really realized what happened in this case. We may have some kind of coronary perforation. So actually, I did quite a quickest or the fastest pericardiocentesis in my life. In just 1 minute, we tried to put the catheter in the pericardium of the patient, and we start to drain, and then afterward, the hemodynamic quite come back. So what should we do at this time? An easy case could become one of the worst catastrophes of your life, as you can see. And actually, we called the cardiac surgeon, but he was quite busy because, it was the evening, and we cannot. He is a cardiac surgeon on site. He only can be in 2 hours, and then we can have one of the most catastrophic cases of your life. So let's take a look at what really happened. So as we can see, it is a quite huge coronary perforation, and actually we did quite fast. We do the pericardiocentesis. We do the prolonged balloon, and this is the same balloon as we do the pre-dilatation, and I was really standing. I was really beside myself at that time. But then we have to calm down because we have to find a solution for the case. And all we know about the theory is that with this kind of perforation, firstly, we have to do the balloon in prolonged balloon inflation. And if the hemodynamic is unstable, actually, we really need to do something like cover stent, or we need to ask the surgeon to fix the perforation for you, which we cannot fix by the PCI. And in this case, the double guiding catheter is a very good technique and very good strategy to do, because we can have more spaces to add on and to put in the devices, and including the cover stent. And sometimes we will need the extension guiding catheter to make it easier to put the cover stent and other device into the perforation to seal that. But always, the old man said, easier said than done. It is very challenging to put in the other device through the second guiding catheter. And we see that with the prolonged inflation of the short balloon, it is really, the hemodynamic is really quite unstable. So we decided to inflate the old stent. We just throw away the stent, and then we use the stent balloon to have a longer prolonged stent of the balloon inflation. So actually, after the stent balloon inflated, prolonged, the hemodynamic become quite stable. And we can see that we can really appreciate that anytime we deflate the balloon, the hemodynamic collapse quite quickly. And after about 1 hour and a half, we have really of 500 milliliters of blood drainage. And actually, at this time, the cardiac surgeon has ready and the OR is ready also. But we don't have any chance to still in this kind of perforation. So we really tried and really take a chance to use a cover stent via the second guiding catheter, and we use a 3/24 cover stent as last resort for the case. And then we hope, really hopefully that the cover stent can cover the perforation. And actually I was really need to take the deep breath at that time, but actually the cover stent seals the perforations. And then the case was quite straight away afterward. We put in another Science Sierra stent at the proximal part of the cover stent and to cover the proximal lesion of the LAD. And then we do the post-dilatation. And this is the final pictures of the case. So this patient is still doing well after 6 months, and he has been seen by me in the clinic, but we have not done any follow-up charity so far. So firstly, we can see that coronary PCI complication can occur at any time, and sometimes with this case, really iatrogenic, so it is really by yourself, so you need to care and aware about that. And sometimes when we should prepare for any situation, and it's better to do PCI when we are well prepared and we are well equipped with a good device and good balloon, for example. And you should never be underestimate any lesions and never do a PCI at any critical moment of your life. And also, the last thing is that you always need help from your colleagues. So in this case, my colleagues, my assistant, my technician, they are also act very fast. And actually, I did go to my birthday, the ceremony of my sister on that day, and I was really happy since I saved a life from my hand. Thank you for your attention.
Thank you, Dr. Ming. So may I ask question from panelists?
Yeah, so congratulations. Yes.
Thank you.
You saved the patient at least, I think. Okay. So what do you think is cause of perforations? Is it your balloon is too big, or because of heavy calcify of the lesions?
Yeah. Firstly, it's due to very big pre-dilated balloon, because actually I ordered only 275 balloon to pre-dilate the case. To pre-dilate the lesion, but due to some reason, this the only balloon that we have at that time it was a 3/25 NC and reused balloon. One important thing is that, and another thing that we really underestimated that reason at that time, because I was very rushing, and then I think that there's some kind of calcify at the middle part of the LD, so that is another reason for the perforation.
I think so. We may have some more comments in this case. So, add some lesson from Dr. Ming. But I think another important thing is you have to thinking about what you have available in your hand. In this case, the doctor tried to inflate a very short balloon because at that time they don't have a longer balloon. So after a few minutes and after a few times to thinking about that, so sometimes we can use the stand balloon. We can throw the stand away and we can use a longer balloon. So we can use that to see the rupture, and at that time we may have a time to prepare for the next step. Otherwise, even when you put a very short stand in this situation, the blood still bleed over the pericardial. Yeah. It is my.
So one another critical point of this case is that sometimes we think that we was really afraid that the cover stand may not enough to cover the whole perforation, because you know the cover stand only can seal the very small hole, but we really afraid that with a very large and big tear of the coronary, maybe it would not be enough to seal that. But we try in this case, and it's succeeded. But actually, we have another option is to send the patient to the OR and ask a cardiac surgeon to seal and to operate on this one. But luckily, we didn't have to do that.
Congratulations to you, but I have some opinion. The second why you use the ping pong technique. The second why you loop wide to advance wide to the distal LD. I think after the patient have the perforate LD, the mixed LD, if you advance the loop with the second why, it make the more dissection and make the big perforate again. In my opinion, you avoid it.
I was very confident at my technique, and I think it is quite critical because we only have about 20 seconds or 10 seconds to do so, because actually anytime you deflate the balloon and then the hemodynamic collapse quite quickly. So I actually at any step you can see that, but we do that very, very fast too.
Okay, thank you so much. So,
thank you, Mr. Chairman.
I would like to invite the last speaker, Dr. Phạm Hồng Cường.
Okay, good afternoon, everyone. Thank you for having me here to share my complication case. I'm Cường from Hanoi Heart Hospital, and now I'm going to present a case that came to our hospital a couple months ago. And she was a 71-year-old female patient. She had a history of hypertension, diabetes, and 2 stents in RCA 1 year ago. And she consulted due to a typical angina, which was CCS3, and her troponin serum and echo in the beginning was normal. And when we took the angio, there was severe stenosis in LAD and left circumflex, which was Medina 011. And the culprit vessel might be LAD with severe stenosis and very calcified lesion. And you can see some signs of calcified nodule in LAD. In the left circumflex, we can see here a CTO in the distal segment, and in the large RCA, stents seem to be fine. So our plan was standing from the left main to LED with EBU 3.5 from right radial artery. And with this severe calcified lesion, we might need rotablation. And then we intend to put 2 wire in LED for cutting technique. That was the type of lesion we had many experience before. Right after we kick off the case, we made trouble to cross the lesion in LED with run-through wire. And during catheter manipulation, we made a big left main dissection. Sorry, I don't have real image here because we did not inject anymore. Back to the case, we could not put the wire through the lesion because the wire was always into the foramen. And the flow in the left coronary arteries began to compromise. And her hemodynamic became rapidly unstable. We immediately inject noradrenaline and inotrope to stabilize the patient. And we made the first challenges, the left main dissection. What would we do? In that situation, we had 3 plans. Basically, we called a surgical team for preparing an emergency K-bridge. But all of operation rooms were on air and only available in less than 1 hour. So our plan was to continue the procedure while waiting the surgeon with less penetrating guiding and try to wire into the true lumen, accounting that maybe we would need mechanical support like IBP. Surely we must not leave it. So let's do this. We chose GL4 with a guiding extension to approach the left main ostium. And after many attempts, the run-through hypercode was crossed the lesion, but we could not advance even the smallest balloon through the lesion. Here we used a 0.75 balloon, but failed. Fortunately, the flow has restored enough for us to think next step. And this is a second challenge, uncrossable lesion. In that situation, we did not think that rotablation with rota-Y could have, because it was filled with a smallest balloon. So we intended to make some more dissection with granuloplasty technique. We made this kind of problem before, and we got them done with this technique. This is the case of restenosis in RCA stent, and the Y was sharpened, and even the smallest balloon were also uncrossable. So we used granuloplasty technique, and then the lesion was more open, and the Y was free to advance. This is another case with severe stenosis and a sharp Y in RCA. We put a second Y and made rupture with a small balloon, and after that the Y can be advanced distally. So let's try this. We use 0.75 and 10 balloon to make intentional granuloplasty. However, it was still failed. Here you can see some hematomas outside the vessel. So we think more and more about K-bridge. However, the flow, it was still okay, and operating room was still on air. So we checked the echo bedside, and there was no pericardial effusion. So we decided to try one more time. Back to the previous algorithm, we might need to increase the support with EBU guiding and another polymer jacketed wire to reach for the distal part of LED. So we kept whole system in place and chose the second guiding with EBU 3.5 from femoral artery, and the wire was filter XTA. And after many attempts, we after many attempts, we could wire to the distal segment of LED, and we made sure that the tip of the wire was in the true lumen. But after many dilation with the small balloon 0 and 0.1 and 1.5 balloon, even with some more granuloplasty, we could advance the 2.5 balloon through the lesion. But it was still an undilatable lesion. And that was the third issue in our case. This is another chart flow adapted by Manoj Brilakis for undilatable lesion. Some people say that our case was suitable for enterectomy, but with many big dissection we have made, we were not sure about its efficacy. This is my previous case when rotablation was used for heavily calcified lesion with many dissection, but the lesion was still not expanded, and we had to use body wide with an NC balloon, and then we made it open fully. Back to our case, we think about cutting technique with body wide and granuloplasty, and kept in mind that we still had the last choice, K-bridge. Back to our case today, we use 1.5 balloon, inflate to high pressure and made it rupture. And then we use 2.5 and 3.0 NC balloon with prolonged inflation. And after more than 20 seconds of inflation, we made the lesion fully prepared. And I want to say that here, it's just 1 more second, but can make everything change. And to save time, I cut some image here to this slide, and you can see many dissection we made and some cracked calcium arc. Now everything became easier. We put 2 stents in element LEDs, just like we planned before. And this is the final result with compromised left circumflex because of dissection. But with the collateral from dominant RCA to distal left circumflex, we think that this result was acceptable. We do IVUS again to check the result, and the stent were fully expanded and well opposed. The patient was stable with symptom-free and discharged 3 days after. And take-home message. The left main dissection is a catastrophic complication in PCI, and the key is keeping the wide entourment and distally. And the reasonable wide balloon combination, like cutting wide with NC balloon or granuloplasty, is sometimes a bailout option in case of uncrossable and undilatable lesion. And finally, surgical backup is crucial, not only in the worst situation, but also for us, like as a mainstay to continue the PCI. Thank you.
Thank you, Dr. Phạm Hùng Cường, and congratulations for the cases. So may I ask our panelists for the question and comments? Dr. Huy.
So thank you. So my question is, I believe that you, the first guiding from radio, you cannot cross the balloon because of you have no backup.
Yeah.
So then you change to femoral.
Yeah.
So when you have a good support from femoral approach,
yeah.
So why didn't you just stand the left main first? Because when you stand the left main, you fix the dissection of the left main, then the guiding can have a chance to go deeper. Then you have more support to do the procedure. Otherwise, you put the patients, you keep the dissection there, you keep the guiding, and then you try to fix the mid of LED. Do you think it's too risky?
Thank you for your question. Actually, with the big dissection in left main, is the high risk with the patient. But when our wide through the lesion and reach the distal part of LED, the flow in the LED was good. It's okay, and the patient was still stable in the bed, and we decide to prepare more to optimize standing.
In a good case, after you success cases with many technique and many equipment, so you lost circumflex.
Yeah.
And it had a good collateral from the RCA.
Yeah.
And lucky for patient. But I think after you use the Gota ablation, I think, do you have a scoring balloon or not?
Yeah, we also have scoring balloon, cutting balloon in my CAD lab. But why didn't you the scoring balloon for this case after a rotator? A scoring balloon is the good choice, But we have many experience with NC balloon and cutting wire technique, so we could use both of the choice. Scoring balloon okay, NC balloon will still okay.
But in my opinion, this situation you use the scoring balloon because the patient have a severe calcium in the proximal RCA. And I was imaging so us you not good repair the lesion before you deploy the stent.
Why is not
the calcium not the rupture after NC balloon?
Here, it is IVERS after we prepare the lesion, and you can see the calcium act was cracked. And so it is evident that we can stand very well here. The lesion was fully prepared with NC balloon and wire.
So the image in this left lower is in the false lumen, I believe.
Yeah.
Do you have, so at that time, do you think better, would you try to wire into the true lumen, or you because you stand that, so, but at that moment, have you think about the double lumen catheter to wire to the true lumen?
Actually, in our case, I'm sure that in the ostium left main, where we were in true lumen, and the distal part of the LAD, we were in true lumen. Because in the middle LAD and the distal left main, we make big dissection and many dissection here, and we make some connection between true lumen and false lumen, and so we the false lumen or true lumen standing in our situation is not important more.
Thank you. Okay, thank you so much, Dr. Honker. Yeah. So I think we finished the second session with a very exciting session of the SSIC awards. So you all know the complication is inevitable in cath lab, so we can learning by sharing. So I myself and I think all of our panelists here really appreciate the information that all our young community of the interventional cardiology to share to us today. So I would like to close this session, and we may have 5 minutes to further next session. Thank you so much.